So I'm going to talk about cancer genomics and pharmacogenomics and what we do at the Center for Personalized Cancer Therapy. We have really put an emphasis in cancer on genomics and more recently looking at the host genome as well. So I'm going to, and I think we're doing some quite novel work, so we'll go over exactly what we're doing there. These are my disclosures, and as background, I do several things at UCSD, but the thing that is closest to my heart is actually the Center for Personalized Cancer Therapy. This is where we do precision medicine and where we're trying to really transform the way patients are treated. I've been here for a few years now. I was before that for many years at MD Anderson Cancer Center, where I founded and led a phase 1 clinical trials department. Phase 1 clinical trials are first in human trials, and by definition, these patients have end-stage disease that is refractory to treatment. And this is really where some of the ideation for what I felt might be the next stage of precision medicine was born. As we began to treat patients starting in 2007 with genomically matched therapies and began to see a glimmer or a glimpse of what proper matching of patients could do for them. So my take-home points, it's actually pretty simple. It's amazing that this is even a take-home point, but we want to give the right drug to the right patient at the right time. We did not have the tools in the past to figure out which is the right drug for the right patient, but we now have those tools, and it's a matter of, number one, using them, and number two, fully understanding them. So some of the points here, at the genomic level, every metastatic tumor is unique and complicated. This is akin to malignant snowflakes. I'm from Canada, so I know a lot about snowflakes. So snowflakes, each one is unique, and each one is very complex in its crystal structure. And that is how we have begun to think about metastatic tumors. Number two, the pillars of precision medicine are genomics and immunotherapy, and they're not siloed, they're married to each other. Number three, metastatic disease, which is really what kills people, is not going to be indented in a major way by single therapies. We need customized, individualized combination therapies, and we've never done that before in cancer. And number four, immunotherapy, which is a really exciting new way of doing things, is interestingly enough best suited for the most complicated tumors. And then finally, I'm going to talk to you about something a little bit different, which is something, the immune pharmacogenomics, which determines response or helps determine response to immunotherapy. And this is very new data. So this is the Center for Personalized Cancer Therapy. At the center of this center is a molecular tumor board. This molecular tumor board has been going on for over 5 years now. It's a weekly tumor board, and we have an electronic version of it as well for patients who need to be discussed immediately. It is a multidisciplinary discussion that includes our physicians, all sorts of different physicians, oncologists, radiation oncologists, surgeons, but also our scientists, our colleagues from the supercomputer center, our basic scientists. Everybody gets in the room together and discusses these patients that have had genomic typing done. And this is not a research discussion. This is a discussion in order to craft a therapy for these patients and to implement a therapy. And we have now done clinical grade molecular profiling on about 12,000 patients, which is actually huge. So I think the only centers that might be equivalent are MD Anderson, Sloan Kettering, and maybe Dana-Farber. We've also instituted a master umbrella protocol so that any patient that comes into the center can be treated if the physician wants to treat them under the precision medicine rubric. As anybody that's worked with clinical trials knows that for most clinical trials, there's about 100 eligibility criteria, which means that about 90% of patients are not eligible for the clinical trial they may be interested in. Here we have a master protocol, just everybody's eligible. And we've published on this molecular tumor board to help disseminate the information about it. Okay, so what has been happening with precision medicine? One of the things that I think is really exciting is that it's decreasing the time for drug approvals. Drug approvals take from discovery until you get a drug approved, it's 10 or 15 years, and that's really too long. And so with being able to more precisely pinpoint which patients will respond, we're also getting faster approvals. And some of this is based on understanding certain major points. So people have been really excited about targeted therapy, but it's really important to remember that targeted therapy in of itself is not effective. And this is a really simple example, but I'm still going to give it. Insulin is a great drug, but not if you give it to patients with pneumonia. And if you gave insulin to patients with pneumonia, you would conclude that insulin is worthless and that pneumonia is very difficult to treat. And unfortunately, probably for the first 20 years of my career, I was doing the equivalent of giving insulin to pneumonia. The bottom line is, it doesn't matter how good an anti-cancer drug is. If you don't give it to the right patients, it's not going to work. So it's all about matching the right drug to the right patients. And we did a meta-analysis of 85,000 patients to look at this. What happens in clinical trials? And this really confirmed what I'm saying here, but it also brought up to light something else that I think is important. So when we looked at response rate over these 85,000 patients, the best response was for targeted therapy with a biomarker, so specifically a genomic biomarker. We don't really understand why genomic biomarkers are better than protein biomarkers. Protein biomarkers work, but genomic biomarkers work so much better. We think this may be a technical issue because the effectors are the proteins, right? But the bottom line is the best biomarkers we have so far are genomic biomarkers. But interestingly enough, although we did this analysis to see if genomic biomarkers were effective in choosing patients, and the answer is yes, we also found something different, which I think is just as important through this study. And this is what we found, that the worst response was for targeted therapy with no biomarker. So actually the worst thing you could do to a patient was take a therapy that was highly targeted against a signal and just give it to unselected patients. And I still think we're doing that probably on 80% of our clinical trials. The median response rate across 85,000 patients with this, throw it against the wall and see if something sticks approach was 4%. So best responses were for genomically driven biomarker studies. Worst by far was when you took a targeted therapy and you had no biomarker and just gave it to everybody. Now understanding the targets and giving these drugs to the right patients has made a huge difference in how fast drugs are approved. So drugs go through 3 stages in cancer, really, to approval. Phase 1, which is first in human, looks at toxicity and responses. Phase 2 looks at response rate, and phase 3 is your randomized trial. If you had told me 8 years ago that the FDA would be approving drugs after phase 1, I would have said that that's crazy. But now the FDA is approving drugs after phase 1. And so no phase 2, no phase 3. First drug to be approved that way is a drug called ceritinib, which was approved for lung cancer. It's a targeted drug. We knew the target, which is the ALK alteration. The response rates were high, and it showed that we could really cut the time to approvals down very significantly by understanding which patients should be getting the drug and therefore getting very high response rates even in phase 1 studies. So this has led to a new era of drug approvals and a new era of studies. And so I want to talk about our master protocol, which we call PREDICT, Profile-Related Evidence Determining Individualized Cancer Therapy. And this is a little bit of a different way of doing a clinical trial. We are treating patients not on the basis of their classic diagnosis, not on the basis of whether they have lung cancer, breast cancer, or colon cancer, which is an organ of origin diagnosis. We are totally treating patients on the basis of their genomic underpinnings of disease. We started this protocol while it was at MD Anderson, and we've continued it at UCSD now. It's both an umbrella and a basket trial, includes all types of cancers, all types of genomic alterations in a master protocol. This is the first rendition of the results from the time at MD Anderson Cancer Center. The protocol was started in 2007 with first-generation sequencing technology at that point. You can imagine how primitive the sequencing technology was in 2007. Yet we could already see that matching patients made a difference. So remember, all the patients that were coming to us, we were phase 1 department, were end-stage cancer. By definition, they had failed conventional therapy and had no options. This is a waterfall plot, which we use to look at response rates in cancer. And everything below the horizontal line is a response. Everything above it is the patient getting worse. So this is the response rate in that setting. When you treat patients with new drugs without any type of biomarker, the response rates are 5%. So very low response rates. These are difficult patients. But you can immediately see that once we started matching patients, even with first-generation technology, the response rates increased substantially. So we began to get a glimpse of what the power of this technology might be. And of course, it's gotten much better over the years. But we found out other things as well, and I'm going to try and show this here. So this is the reclassification of cancer. If somebody has a cancer, the first thing that they go to their doctor, and the first thing we want is a diagnosis, because that's how we treat patients. And the diagnosis is based on organ of origin. Do the cells come from the lung? They're lung cancer. Do the cells come from the breast? That's breast cancer. But that doesn't tell us much or anything really about the biology of the disease. So when we began looking at mutations, we discovered something that was very interesting. And this is about an example with the PIK3CA mutation. This is a driver mutation found in about 10% of cancers. And what I want to point out, it's found in a lot of different cancers. It doesn't follow the organ of origin rules. And I don't have room on this slide, but if you took almost any type of cancer, there would be a subset of patients that have this mutation. So one of the first things we discovered was that molecular aberrations do not segregate well by organ of origin. So this is making us rethink our classification of cancer based on a genomic classification. And here's another example, HER2. HER2, we looked at almost 38,000 patients. This is a very interesting target. There's approved drugs in both breast cancer and stomach cancer for patients that have this target. But then when we looked at 38,000 patients, what you can see is it's not just breast cancer and stomach cancer that have abnormalities in this target. It's all sorts of different cancers. And in fact, some of them have abnormalities much more commonly than breast or gastric cancer. Bladder cancers have common abnormalities in this. Gallbladder cancer, really difficult disease to treat. And then salivary duct tumors, 60 to 100% actually have abnormalities in HER2. And we already know from data that's coming out in the literature that if we use these drugs that are approved in breast cancer or in gastric cancer for these other tumors that have this abnormality, they can become extremely effective. And I actually expect that in the near future, these drugs will be approved for these other cancers as well. That has led to the birth of a new era, and this was, I think, a watershed date, May 23rd, 2017. The FDA approved an immunotherapy called pembrolizumab, and this is a new approval. It's the first, but certainly not going to be the last. And it really changes everything for cancer approvals. So the first thing is, this approval was tissue-agnostic. It was for all solid tumors. It wasn't an approval for lung cancer, wasn't an approval for breast cancer. It was approval for all solid tumors. That's the first time that's ever happened. Number two, the approval was based on a genomic marker. These patients have mismatch repair gene defects that are lead to responses, and so this was the first time that a drug was approved based on a genomic marker, and it didn't matter which solid tumor you had. And number three, this is the most important part, and the part that most people don't actually realize. Approvals by the FDA are based on prospective data, on doing clinical trials. But for this approval, the FDA allowed a substantial amount of the approval to be based on retrospective data mining. And I can't underscore how important that is, because doing prospective trials in all solid tumors would take another 10 years. But they allowed retrospective data mining. We have tremendous computer capabilities now to mine data. And this green-lighted, in a way, the possibility of using that data rather than just prospective trials to go for approvals. Okay, but as the technology got better, and it got much better, we began to run into obstacles. And so I want to talk about what's happened. The first human sequence took 13 years to sequence a human genome. Now it takes about a day. The first human sequence was about $2.7 billion in 2003. By 2007, it was down to 100 million, still a little bit high for your insurance. But now it's about $5,000. So now this is usable in the clinic. But now being able to sequence, now we have a new problem. We have great technology. It's not like in 2007 where we did one gene at a time and we ran out of tissue after you looked at 3 genes. Now we can do full human genome sequencing, and this brought us to the problem of complexity. And the fundamental premise that I said before about every metastatic tumor being both complex and unique. So here is an example. This is breast cancer. We've done now thousands of patients, and this example holds true, but I can't put 1,000 patients on a slide, so I'm just going to show you this. This is sequencing based on next generation sequencing, 236 genes, and these are the abnormalities in 13 successive patients. What I want to point out is that each patient has multiple abnormalities, or most patients have multiple abnormalities. And second, that no 2 patients have the same abnormalities. Now let's take these 2 patients. They have an abnormality in common called ERBB2 amplification. So normally we would give them the same drugs, but see how that doesn't fit what the genomics is telling us, because even though they have ERBB2 amplification in common, the rest of their genomic portfolio is different. So this has brought up the idea that each patient needs their own customized combination. And we've never done things like that before. That's a problem for us. When the science reveals that what you've been doing for the last 50 years is not optimal. And we're just at the tip of the iceberg. There's not just genomics, there's transcriptomics, proteomics, epigenetic changes, and so forth. So let's look at how our clinical trials have evolved. We started out thinking that lung cancer was one disease. Now we realize it's multiple different subsets of disease. We've moved from looking at a cancer's organ of origin to looking at genomics from multiple different organs. And from large randomized trials to smaller trials where we hope that most patients respond. And that's stage one. But we still have stage two, which is the customized individual combinations. And if each patient needs a specially tailored treatment regimen, there's some problems with that. If there's 300 drugs in oncology, the number of 2-drug combinations is about 45,000, and the number of 3-drug combinations is 4.5 million. And in oncology, we've always had to do a phase 1 study for every drug combination. That's not going to happen. It's going to take 1,000 years. So in stage two, we need to change our thinking and move from the drug being the center of the universe to the patient being the center of the universe. And do a strategy of customized drug regimens. So let's see how this works out. Traditionally, the drug is at the center of the universe, and patients with different abnormalities all go on the same drug. Initially, based on organ of origin, you have lung cancer, you go on a lung cancer trial, you have breast cancer, you go on a breast cancer trial. Now, based on a genomic abnormality, a single abnormality will put patients on the same trial. But we know that those patients with a single abnormality in common, the rest of their portfolio is different. So this is not optimal. So instead of using a consistent drug between patients, even in the presence of different molecular profiles, use a consistent strategy, but allow different drugs. So what does that mean? In the patient-centric trial, every patient gets its own combinations. And I want to mention how this personal incident that actually made me think about this. This is a patient with breast cancer. Actually, was a good friend of mine. She was on TDM1, which is a HER2 targeting drug. At relapse, she was found to have a PIK3CA mutation, and we suggested to add an mTOR inhibitor, which targets the PIK3CA mutation. But her doctor said, we can't do that. There's never been a phase 1 study of the 2 drugs combined. And she sent me an email, this was about 4 years ago, that really changed my thinking about everything. And this was what her email said. She's on this anti-cancer drug, but because she'd been ill for a while, she was on about 15 other drugs. And the title of the email was, where is the safety data? In other words, you can't add a single anti-cancer drug to my regimen because it's never been tested in phase 1, but I'm on 15 different drugs, and they've never been tested in phase 1. She was actually a physician, and I'll say it that unfortunately she just died. So patient-centric therapy. We already customize treatment every day. Every physician does this, except in oncology. Oncology is actually the exception. If we have two patients with diabetes, but one has heart failure and arthritis, and one has infection and depression, they don't go on the same regimen. They go on different regimens. So oncology has been the exception and needs to stop being the exception. So let's talk about the marriage between genomics and immunotherapy. Because this is, I think, the next big frontier. So the pillars of precision medicine are genomics and immunotherapy, and people think about them separately, but they're a couple, and they're married to each other. And how do we know this? Well, the way immunotherapy works, our most common drugs, like the checkpoint inhibitors, is they reactivate the immune system. The tumor turns off the immune system. The immunotherapy reactivates it. But what we know is the second step to that is that the immune system has to be able to recognize the tumor. And the way it recognizes the tumor is by the number of mutations it has. So the more mutated the tumor, the better the response to immunotherapy. So these messed up tumors that we thought we would never be able to treat, they are the best tumors for immunotherapy, because once reactivated, if you have hundreds of mutations in your tumor, the immune system immediately recognizes that that doesn't belong there, and it eradicates it. So I'm going to just skip over this. So let me just talk about how this works out in the clinic, give you some examples of super responders and optimized response to immunotherapy. Here's a patient that came to our clinic, metastatic basal cell carcinoma. It's a rare tumor. He'd had 6 different treatments, including the FDA-approved targeted therapies, which didn't work for him at all. So let's see why they didn't work for him. This was his next generation sequencing. First of all, you can see he has a lot of different driver alterations. He has the driver alteration that is targeted by the FDA-approved therapies, but we can immediately see why it didn't work. It didn't work because he has another 20 mutations. So how could targeting one of them work? So we saw that he has what's called a high tumor mutational load, and on that basis, we treated him with immunotherapy. And so this man went from being, and we've seen this now several times by matching patients to the right drugs, from being really hospice-bound to doing great. This is his tumor before, this is his tumor after 2 months. It's now about 3 years. I saw him in clinic about a week ago, and he's doing great, off therapy, complete remission. That's why people have gotten so excited about immunotherapy, because we can take patients that are really very ill and put them into complete remission for the first time. But you have to choose the right patients, and the right patients are the ones with a high mutational burden. Cutting-edge technologies needed for complicated cancers. I want to talk about some of our new technologies. And so we've been doing genomics on tissue, but now we can do genomics. This is amazing. On a blood sample or a urine sample, the blood is really much more sophisticated, and we've done about 3,500 patients, clinical grade genomics. And what does this give us? I'm going to give you a patient to show you an example of what this gives us. This is a 49-year-old woman from Saudi Arabia. She came to us at the end of 2015. She had surgery, chemotherapy, radiation, nothing worked, and she was very ill. She had this huge abdominal tumor, looked like she was 7 months pregnant, bowel obstruction, kidney obstruction, probably just had a few days left to live. So we wanted to see if we could do anything. We didn't have time to get tissue genomics, to get a biopsy in genomics. So we did a blood test on her. And this is what the blood test showed. It showed that she had multiple alterations. So we guessed that that meant that she had a high mutational load that hadn't been shown before. But just on the basis of that blood test, we treated her under our master protocol with immunotherapy. This is her tumor before, her tumor after a few months, and she left after 1.5 years to go back to Saudi Arabia in complete remission. When we did the tissue genomics, it confirmed what we saw in the blood. Look at all those alterations. She had a high tumor mutational burden. This is why she responded. So I'm just going to skip over this, and I want to get to this. Okay, so what about the host? This is, what about the host? This is a real picture. So is this woman who is, smoking like a chimney and healthy at 100, is this good luck or is this her genomics? And what I want to say is that this is her genomics. I'm willing to bet that this was not just good luck. So what are we learning about pharmacogenomics? So the purpose of pharmacogenomics, as you know, is to develop effective, safe medications and doses that will be tailored to a person's individual genetic makeup. And now that we're doing customized combinations, that is even more important than it ever has been before, because this is something we really have to understand. And pharmacogenomics can help us understand everything from receptors, absorption, you heard about excretion, and immune system response. This is a classic pharmacogenomic study, and then I'm going to show you what we're doing with the immune system. So irinotecan is a drug that treats gastrointestinal cancers, inhibits topo1. If we look at the UGT enzyme, we can predict patients that may have more serious toxicity with this drug. So again, pharmacogenomics can be really important as we begin to combine drugs and look for, are patients going to have excess toxicity because of combinations. But we're now opening up an area, and this is what I want to finish with, is of the immune pharmacogenome. And this is really recent data, but I think it's really, really exciting. So how you respond to immunotherapy depends on the drugs, it depends on your tumor, but it also depends on your immune system and how your immune system presents the tumor. So the immune system has this it's really actually pretty phenomenal. It has the MHC1 and the MHC2, and I actually think it's like, it's pretty interesting, like cells holding up a sign and saying, look at these neoantigens. Do I belong here? And then the T cells circulate and get rid of cells that don't belong there. And so this MHC1 and MHC2 are both involved in responses to cancer and in eliminating cells that don't belong there, whether they're bacterial cells, viral cells, and so forth. So what has been really recently discovered, just published, is the anti-cancer immune response against mutated peptides of potential immunologic relevance, neoantigens, is primarily attributed to MHC1 restricted CD8 positive T cells. And a paper from UCSD recently published showed that the oncogenic mutations arise in gaps in personal MHC1 presentation. In other words, the way your MHC presents decides what kind of tumors you can have. And the neoantigens, the mutations that are well presented, you're not going to get that tumor because it's well presented. It's the neoantigens or the mutations that are poorly presented that are going to result in tumors. So this has led to this study that we haven't yet published yet, but I think it's really interesting. So we are looking at patients, and we know that patients with high tumor mutational burden do better with immunotherapy. But within those patients, about 50% respond, about 50% don't. And when we look at their MHC1, we can actually tell which patients within the group of patients that have more mutations will respond. It's the patients that can present those particular neoantigens that actually respond the best. So it's not just about the mutations that you have in the tumor, it's about how well your own particular MHC presents those mutations to the immune system. And so if we give a drug that reactivates the immune system, you have to have mutations that are going to be presented. The more mutations you have, the better response. And the more that your own MHC can present those mutations, the better your chance of response. So I think the host is going to be critical now to our understanding of immune responses. I'm just going to finish by saying that precision medicine is not just going to change cancer, it's going to change all of medicine. And to me, this example is fascinating. The FGFR3 mutation is present in bladder cancer. It's a somatic mutation. We now have FGFR inhibitors that are in the clinic. Very interestingly, in the germline form, it's responsible for some forms of achondroplastic dwarfism. And it's the same mutation. So this brings up several questions. Number one, why are the people with this achondroplastic dwarfism do not have a higher incidence of cancer? What are their compensatory mechanisms? And number two, could we use some of the drugs that we're now using to inhibit the abnormal activity of this FGFR3 in bladder and other tumors to change the phenotype of people born with achondroplastic dwarfism? Of course, that's a really big question, but it has actually been tried in mice, and it does work in mice. So I think that opens up whole new questions, whole new frontiers. And I'll finish with that, and if you have any questions, I'm happy to answer them.
Okay, thanks very much. We do have time. Do you have time for a couple questions? Let me ask you just one, as a non-oncologist. The mutational burden criterion for immunotherapy sounds like a good way to approach this new era in cancer therapy. But how is a judgment made as to where that threshold is for the multiple mutations that qualify for immunotherapy?
That's a really good question. There's now an effort to harmonize mutational burden calculations across multiple different vendors. The one that we've used is actually Foundation Medicine, and their cut point is 20 mutations per megabase or more is a high mutational burden. It's sort of an arbitrary cutoff. And what I will say is that when we looked at our data, which we published, there is a linear correlation between mutational burden and response to checkpoint inhibitors. There is actually no inflection point. There's nothing magic about 20 or any of the cut points that have been getting. It's absolutely a linear relationship.
Snowflakes are really complex.
Yeah.
Okay, we have a question here.
Yeah, there's a lot of companies that are selling, if you get cancer, they'll look for mutations, and also panels of mutations they look for based where the primary tumor is based. So I was just wondering, since you're ignoring where the primary tumor was and you're just looking at all the mutations in general, is there like a panel of genes that you're looking for that you run every time? And if so, is that available for the public to know what that list is?
Yeah, so our physicians are allowed to order from any legitimate lab, which means that they have a California license and they're CLIA. Probably the most common places that they look for is actually UCSD has a next generation sequencing lab, and the other one is Foundation Medicine. So Foundation Medicine, I think their assay is about 315 genes for solid tumors and 405 genes for hematologic malignancies. They actually recently gained FDA approval for their assay. Considered, at least at the quality for FDA approval, as you know, you don't need FDA approval for an assay to be usable in the clinic. It needs to be CLIA, basically, and California certified. But I would say that Foundation Medicine and UCSD are the most common places that our physicians will order from.
Okay. One more question, Mary.
So UCSD, you've been doing this for a really long time, as you mentioned, having your molecular tumor boards. How do you see this being extensible across cancer centers throughout the U.S.? And are there some efforts to harmonize this approach to reviewing these mutations in cancer patients across at least this country?
I think those are really good questions. So I do think we had one of the first molecular tumor boards, but they've now sprouted everywhere. So there's tumor boards all over the place. And so one of the issues that you brought up is the quality of the recommendations from the tumor board is based on the expertise of the who's running it and who's coming to it. And I think that can be very variable. But I'm going to say something the opposite too. I actually think that at this point it's probably important not to harmonize it, even understanding about the variability of the expertise. None of us really know perfectly how to put all this complexity together. And I think at this point it's important to have various ideas allowed to blossom in different places. So acknowledging that some molecular tumor boards are perhaps don't have as much expertise as we might want them to. I do think that there's other ideas of how to do this. People are using avatars that are in animals or avatars that are organoids and so forth. And it's important to allow tumor boards to explore these different ways of doing things rather than making everything uniform at this point in time. Okay, thank you.
Thanks again. Great talk.